Welcome everyone, and thank you very much for inviting me to speak today. The big six challenges. I think, first of all, we have to kind of say, well, what is interoperability? I'm aware it's a pretty mixed audience. So what is interoperability? So I've used a Google definition, which is health interoperability means the ability of health information systems to work together within and across different organizations to advance the effective delivery of healthcare for individuals and communities. And I won't spend too long just saying why that is important, but it's really important from a patient experience point of view, from an efficiency and a clinical and an efficacy point of view. It's all about delivering better outcomes and a better experience for the patient at the end of the day. So I'm going to talk a little bit during my presentation around different interoperability standards. So I think it's just worth mentioning, what those are. Please ask questions afterwards around it. But there are a number of standards. So when the systems in the 90s, when I first started doing working in digital health, systems didn't talk to one another. And then in the the early 2000s, there was a standard called HL7, and that basically allows data to move from one system to another. So if you admit a patient on the main patient administration system, that patient would get admitted in the radiology system and other systems. So started fairly basic, and then newer standards, something called FHIR, which is brings the internet into things and the web. So it should allow you to access data using mobile devices, for example. DICOM, which is used for moving images. Something called XDS, which is for non-structured data like documents. And then most recently, I guess it's been around, is something you may have heard of called OpenEHR or OpenAir, which is a way of storing data. So ask me questions about those, but I'm going to mention those during my presentation. So just a little bit about me before I start. I've been 32 years now, coming up 33, in working in digital health, always on the vendor side. And my passion has always been around interoperability and data sharing, or certainly since the early 2000s. I developed and implemented some of the first HL7 bidirectional interfaces in the NHS, developed and implemented NHS numbers for babies, so maternity system and processes have a place in my heart. In 20 maternity units, I worked on the national programme for IT, on local and national integrations around radiology workflow. I designed and implemented those workflows in the London Diagnostics Programme. I've designed interoperability, HL7 capability for a PACS vendor and an EPR vendor. And over the years, I've been a member of HL7, all the various integration bodies, HL7 UK, IHE UK, Interopen, and I follow the OpenAir community. Crucially, I've experienced integrated care. So with the ICSs being newly formed now, I've actually been to a country that has implemented integrated care at a county level, and that's Sweden. But they do it with one system across. And what the NHS is trying to do is achieve that same thing, but using multiple systems. And really this presentation is exploring some of the challenges around doing that. So who is Restart? We've been around for 17 years. We've developed over 2,000 interfaces for 80 healthcare organizations. We're currently supporting over 35 organizations with round-the-clock integration support. We've connected to over 90% of the systems out there on the market. We talk about open technology principles. What that means is we're vendor neutral. We work with all the systems and all the standards. So you can see a few of the standards there that I've just been talking about. We have the largest interoperability resource pool in the UK with over 35 trained engineers in the UK, and we're based in Exeter, Devon. So one of the things I know Restart's proud about is investing in local talent and providing technical jobs in the southwest of England through the Restart Academy programme. So that's working with Exeter University, and I think Cardiff as well we work with as well. Our sector, we do a lot of work at the front line, actually developing the interfaces. So we talk about this bottom-up approach. with ground up approach. So we understand it from kind of top to bottom. We walk the walk as well as talk the talk. And our mantra is think big, start small, scale fast. This is a massive task. And how do you eat an elephant? It's one bite at a time. So we always encourage that. Start small and scale up, but have a big plan. In some of my slides, you'll see reference to IMX, and so I always get what is IMX. So IMX is literally, it's restart secret source. It's how we deliver interoperability projects. It stands for interoperability matrix, in case you're wondering, and the matrix consists of our professional services, our skills. We have software and elements as well, the IMX platform, which is the interoperable clinical record. We provide technical support, and we work with partners as well. So quite often you need to bring other things in to solve a problem. And we work across the whole plethora of different care providers, including voluntary services, local government, social care. The majority is still acute trusts and a bit of primary care, but obviously things are going to have to change to truly connect everything. So what are the 6 challenges? So our view, when we looked at this about 10 months ago, we thought, what are the big challenges? I've listed them there, and we'll go through them in a bit more detail. The first one is digital maturity of organizations, consolidation of systems, or convergence as it's been called as well, intra and inter ICS working, so within a region, getting everything joined up, but also when patients move across borders, what happens then? So inter working as well, patient apps and point of care devices. Certainly with a big push towards virtual wards and remote monitoring, keeping patients away from hospitals wherever possible. Diagnostic alliance hubs and merger of trusts. They're the 6 we have identified. So if I start looking at digital maturity, organizations such as mental health trusts, community trusts, and local authorities providing social care quite often are less digitally mature than acute trusts and primary care, and don't have that capability or capacity to integrate to meet the requirements of integrated care systems. These less digitally mature organizations will need to plan for how they close this gap. As a minimum, they will need software platforms and integration skills to enable ICS requirements, such as remote monitoring, patient engagement platforms, real-time command and control dashboards, population health analytics, and longitudinal patient records. All of those things are built around interoperability and the ability to share data, quite often in real time. The software is the easiest part, as there are excellent integration platforms on the market and already deployed in the NHS. However, there is a skills shortage in the skills required to design, build, maintain, and support the interfaces that these platforms enable. This is where having a partner such as Restart makes absolute sense, because we can help less digitally mature organizations by being their interoperability partner with this specific domain expertise to advise on the plan and provide the necessary skills and software platforms to deliver integrated care on a case-by-case basis, depending on the individual needs of the organization. Convergence of EPR systems, so consolidation and convergence, and I think is convergence of EPR systems, as I talked about Sweden, they have in the majority of the Swedish counties, it's one system that's run across the entire county for all care. So it's a single record. That approach in the NHS, I just don't think will work for various reasons, but because it's just a more complicated environment. But convergence of EPR systems within the NHS is probably a good thing, as opposed to divergence anyway. And having the same EPR system as another NHS organisation within an ICS should, theoretically at least, reduce the complexity around sharing information between organisations, especially if organisations share a single instance of an EPR. However, interoperability and data management issues arise when changing from one EPR to another. One challenge is ensuring that all the interfaces connected to the outgoing system are replicated in the new system. When replacing a PAS, these interfaces are normally related to patient and activity messages, such as ensuring that patient demographics are up to date in critical systems, such as the emergency department, ensuring that appointment details are kept up to date in departmental systems. When replacing an EPR, however, there can also be a significant amount of clinical messaging, such as clinical alerts, allergies, orders and results, which are fed down to downstream systems. The other side of this, once the as-is status has been preserved, is to identify new data in the new EPR that can be integrated to potentially deliver benefits through new ways of working. Each PAS EPR replacement will be different, so it's important to have a solid and proven methodology to replacing these interfaces to ensure that no data which enable current business processes are lost, and that any new data can deliver efficiencies or improved outcomes they're identified. We've developed such a methodology, and that's been implemented several times at organisations such as Taunton and Somerset, NHS Foundation Trust, Barking, Havering and Redbridge University Hospitals, NHS Trust, and the Royal Brompton and Harefield Clinical Group, to name a few. A second challenge is related to the migration of the data from the outgoing system to the new EPR. NHS organisations have learned that this is a highly specialised task, and if you get it wrong, it goes really badly wrong. Think back to the national programme. And there are organisations that do this very well. However, on average, only 20% of the data is normally migrated to the new system, which means that the vast majority is left behind. The data is often still useful and relevant to patient care, and having real-time access to this legacy data in patient context from the new EPR is very important. So again, we provide the IMX platform allows us to, and we've deployed this at South West Yorkshire Partnership, NHS Foundation Trust performs this very task. So it provides a seamless user experience for the user to be able to access legacy data that hasn't been migrated. Intra-ICS working, so within an ICS, within a geographic region. Shared care records have been quite popular in the last few years, and they're seen to provide a longitudinal view of a patient's record within a geographic region, such as an ICS. Interoperability lies at the heart of every successful shared care record. They can only fulfill their role as the central access point for health and care data if that data can be correctly sourced and efficiently populated into the solution, an essential step that is often overlooked in the early stages of a project. Low digital maturity and a lack of interoperability from some vendors, especially in primary care, are barriers. Semantic interoperability of data is an issue for analytics. So semantic interoperability is, how do you compare apples with apples? If one vendor stores clinical information in this format and another EPR stores clinical information, when you put that together in a shared care record and a clinician sees a conflict in the data, for example, the patient is allergic to penicillin in this system but not in this system, the clinician will ask the patient, are you allergic to penicillin? But analytics algorithms can't do that. So the way forward is to use coding methodologies such as SNOMED-CT The barrier to doing that is how do we get clinicians to code data without slowing up clinical processes with the patient. Scheduling of services across multiple providers within ICS to support a complicated pathway is a massive interoperability challenge. Either a new scheduling service will need to be layered across all providers and integrate with local PAS systems and UPRs, and it will need to exchange scheduling information bidirectionally, which will probably be even more complex. And in a similar vein, workflow interoperability, because everything I've been talking about really has been data, but actually we can move the data around between the systems. But from a user perspective, if you're working on a complex pathway that involves multiple organizations and multiple systems, logging in and out of systems is not an enjoyable experience. So the workflow interoperability is a challenge where a consistent user experience is required, where users do not have to log in and out of these systems. And at present, I don't think shared care records provide a good solution to this. Current solutions and interoperability capabilities as we stand today are not quite there, but there are some interesting projects going on around workflow. Inter-ICS working is also interesting. So I mentioned before, and I've got a little graphic here showing it, a patient in Cornwall needing to go to, I think that's Bristol, for some, if they're a cancer patient, they may need to go there. So the deployment of shared care records across England will solve many of the interoperability issues faced by the NHS, but will not create a readily accessible longitudinal patient citizen record. Data that is currently held at system level will instead be siloed geographically, reducing some local data sharing issues, but not eliminating them. Access to vital data will not be improved for cross-boundary care or out-of-area patients. So further interoperability will be required there as well. Connecting regional solutions together will be a huge challenge, given the use of different proprietary shared care record solutions out there at the moment. So an alternative solution is required for this problem. And my view is that if every shared care record has open APIs as well, then it is possible to layer a consistent, give that consistent longitudinal view using another user interface, for example. The next challenge, and I think this is really, really relevant at the moment, is around what I've called patient apps, but this is quite a large bucket. So in this, I'm talking about patient engagement apps that handle PIFU, patient-initiated follow-up, for example, right down to remote monitoring solutions and that enable virtual wards. There's real growth in these kind of what I call patient apps banner. And the reason is because they're allowing patients greater control and flexibility when it comes to engaging with healthcare providers. And it's giving them an experience that citizens are used to in other sectors, such as retail, financing, travel. They have far more control over when they come in and how they engage with the providers. And the plethora of remote monitoring and virtual ward solutions that the NHS is so keen to invest in. The reason why these types of solutions make sense is pretty obvious. For the cohorts of patients for which they are suitable, and this is also an important subject and probably outside of the scope of this presentation, is they enable the patient or the citizen greater choice about when and when they engage with clinicians and care providers. It is one massive element of digital transformation that has affected us all since the pandemic, like today, us meeting together in this way. Yeah. On the face of it, it's a win-win for both the patient and the provider. However, to be truly effective and safe, I believe that these solutions must be tightly integrated at an administrative and a clinical level. When a patient chooses not to attend a follow-up appointment using PIFU, then this must be recorded in the PAS scheduling system to prevent overbooking or wasted slots. Similarly, clinical data that is collected remotely must be fed into the EPR and make full use of any clinical decision support algorithms that support the clinician. And this provides the same level of care as if you were in the hospital. Diagnostic alliance hubs have the potential to provide efficiency and savings by providing centralized capacity and capability for diagnostic laboratory services. In order to achieve this, all the different systems that make requests for tests and receive results, so where everyone used to have their own laboratory, if multiple providers are sharing a laboratory, they need to be integrated to the central laboratory system. This is achieved by integrating the individual trust integration engines, TIEs, with a high availability regional integration engine, which can handle all the inter-trust business rules, as well as integrating to the laboratory and reporting services. And then the final challenge, challenge number 6, is trust mergers. So there have been quite a few of these. I still think they are happening and will probably continue to happen. So when two trusts merge, there are normally at least 2 types of every system: PAS, RIS, LIMS, etc. No matter what the strategy is for consolidating these systems, there will be lots of changes required in integration engines to reflect these changes. For example, if one radiology system is retained and the other decommissioned, then interfaces will need to reflect that all sites will be using the same system as a single organization, rather than 2 separate organizations using 2 different systems. In some cases, depending on the systems involved, it is possible to synchronize activity across the different systems to support a unified process. Even if the newly merged trust decides to commission a new EPR, then new interfacing will be needed to support the new workflows and legacy interfaces, which is basically the convergence problem again. So they are the 6, and kind of looking ahead, and these are just some of my reflections. I think what we're seeing is at Restart, still the vast majority of interfacing and integration is still being done using HL7. So this is going from big system to big system. A lot of things are still on premise. The direction of travel for healthcare will be towards the cloud, same as every other sector. What we don't know is the speed, the velocity that we get to cloud. Fire has promised a lot, and I think so far not quite delivered on that promise. And I think a really good reason for that is that the standard of fire that the NHS used, which is called STU3 or users, isn't really supported by those big American vendors that are very popular in acute care. There is a new version of fire coming out, release 4, and this is going to be a normative release, and everything should be synchronized then. So the NHS and the US are on the same version of fire, and I'm very hopeful that this will open up lots of new interoperability opportunities, especially with regards to patient-facing apps. And for OpenAir, it's something that I've followed for over a decade. It's really gathering momentum, really everywhere outside of the US. But certainly within Europe and Asia, it's growing as a standard. And the idea behind OpenAir is that traditionally, every software provider will have, the people that develop the software are obviously software developers. I used to be one. And they, in each organization, will have a clinical expert, and they'll say, how do we store blood pressure, for example? So they all do it differently. OpenAir is different, and the clinicians define how the data is stored. So it's a common storage standard. What we need to do in this country, in my view, is do something similar to Norway, where the government defines this is how we store the data using OpenAir. In this country at the moment, it feels a little laissez-faire, and some of the benefits are being lost. But I know that there is talk around an OpenAir UK organisation. And as I mentioned before, integrated workflow, consistent user experience is a real challenge. So they're the 6 challenges for ICSs. What we at Restart are encouraging ICSs to have is have a plan, have a platform, and have a partner. Thank you very much.
Thank you very much, Andy. We've only got a few minutes left. Any questions for Andy at all, anybody? Or observations, opinions, whatever you feel like, really? Well, I'm gonna throw one in. I'm going to be a little bit controversial. I think you've got one missing, which is, so what? What are we trying to achieve? And the having the plan, having the partner and so on, I think that's great. I absolutely agree. The bit that I'm struggling with is, what are we trying to achieve with these digital technology solutions within the ICSs? What are they for? Who are we trying to benefit? That's the big thing for me.
I think it should be to the benefit of everyone, John. Yeah, it's the benefit to the patient. It's about improving safety. It's about improving outcomes. And I'll end with a little true story. I used to be the product manager for a maternity systems company, and my son was due to be born in Basingstoke, and he arrived 6 weeks early in Sheffield. And I remember, and it was the firstborn, and it was early, and I remember sitting there with midwives looking at my patients and my wife's handwritten notes, going, "What does that say? I can't read that." And that, to me, summarizes why this is so important, because we need better information to make better decisions, no matter where you are in the country, to support the clinicians, to provide better care, to give better service to the patients.
Well, amen to all of that. I don't think anybody's going to have any doubts about that. Shane, you've got your hand up.
Thank you, Andy. Thanks for a great presentation. Really enjoyed it. Super good.
Thanks,
just a couple of points, if I may, and I want to add to your convergence, open air.
We have only got a couple of minutes, Shane, so I'm going to have to hurry you along a little bit. Thank you.
So on the convergence, just to be really clear, although convergence is often talked about as systems, it isn't. Convergence is about standards. It's about the flow of information and interoperability.
Absolutely.
Even though the leader has talked about, standardize where it makes sense, but the forums and the money is actually about convergence of those things to make that data flow. Open air in a common data model sense, although I know it's got a lot of traction, it only makes up about 10% of some of the data really to support an ICS and clinicians. And there are a number of common data models. I know about the NHS one. I happen to be working on one in London, and that's where I know that standardization to SNOMED CT is becoming more popular in Wales and Scotland, and now the English CIOs at ICS levels are getting there too. Hope that was brief enough, John. Thanks, Andy.
Yeah, and I agree with all of that. And just on that, I think the systems and the process and the data, it's so tightly entwined, it's kind of cart and horse, and an open air, yes, it isn't complete, but it's an open standard and it's open source, and clinicians can define what's not there going forwards.
All right, thank you all. Good question, Shane, good observations as well there. Thank you very much. So I hope you enjoyed that, everybody. We're trying to bring more content, more presentations, more opinion pieces. We may even have the opportunity for some Oxford Union style debates. I know Mary and I are both kind of wary about using this Oxford Union kind of idea, because we know how breathtakingly, well, no, let's not, I'm not even going to go down that route, actually. Let's just move straight along. But that's what we're trying to do, trying to create a little bit more richness of content for you. And Andy, you've done a super job there. Thank you very much indeed.